I am Mario Cazzola, a professor of hematology at the University of Pavia Medical School, Pavia, Italy. I am currently conducting translational research in myeloid neoplasms, focusing on myelodysplastic syndromes or MDS. Between 2014 and 2016, I participated in the preparation of the WHO classification of hematologic neoplasms, collaborating with pathologists and clinicians. The WHO classification, 4th revised edition, was published initially in 2016 in a special report in Blood, and in 2017 in the Blue Book of the International Agency for Research on Cancer. We then prepared for an update of this classification, and in 2020 we contacted the WHO, International Agency for Research on Cancer, for preparing this update. We learned that the International Agency for Research on Cancer was no longer interested in collaborating with hemopathology societies and in using the approach we previously used, that is a clinically advisory committee. Therefore, a group of pathologists and clinicians decided to proceed independently and to organize the International Consensus Conference in Chicago in September 2021. And this led to the development of the International Consensus Classification of hematologic neoplasms. Here I will discuss the classification of myelodysplastic syndromes and especially new nosologic entities that we have defined in this work. I did my MD thesis working on the assessment of ineffective erythropoiesis in patients with refractory anemia with ring sideroblast. I found images like these ones not only extremely useful for the recognition of erythroid dysplasia, but also beautiful. They reminded me of pictures of the French pointillism, like this picture, La Calanque, by Paul Signac. But it took me several years before I understood the pathogenesis of ring sideroblast. In 2010, within a European collaboration, we decided to perform next-generation sequencing in patients with myelodysplastic syndromes. We reasoned that specific morphologic abnormalities were very likely to be underpinned by specific genetic lesions. So we started from patients with refractory anemia with ring sideroblast. And we sequenced initially 8 patients, and 6 of them were found to have a somatic mutation in a spliceosome gene called SF3B1. And follow-up studies showed a close relationship between SF3B1 mutation and ring sideroblast. This condition is a benign disorder with a median survival of about 9 years, at least for patients with isolated SF3B1 mutation, and a very low risk of leukemic evolution. And additionally, these patients are very likely to respond to luspatercept with the abolishment of the transfusion requirement. So in the International Consensus Classification of myeloid neoplasms, we defined the new entity called SF3B1-mutant MDS, which is characterized by peripheral blood cytopenia, no excess blast, SF3B1 mutation with a variant allele frequency of at least 10%, and the absence of a TP53 multi-hit state or RANX1 mutation. Several genes can cause MDS, and TP53 is one of them. Overall, TP53 mutations are associated with poor clinical outcomes, but a specific genetic state of TP53 is particularly important, that TP53 multi-hit state, which can be defined as follows. So, through a combination of genetic lesions, both alleles are targeted and inactivated in the TP53 multi-hit state. This condition is also called biallelic mutations in TP53. The International Working Group for Prognosis in MDS has studied the relationship between TP53 multi-hit state and clinical outcomes in MDS. Elsa Bernard and Ellie Papa-Emmanuel have been primarily responsible for these investigations, and the study was published in Nature Medicine in 2020. So we found that MDS patients with monoallelic TP53 mutation, orange curves, are substantially not different from all patients, gray curve, in terms of overall survival and cumulative incidence of leukemic evolution. By contrast, patients with multi-hit state, blue line, have a worse overall survival, below 1 year, median survival is below 1 year, and a very high risk of leukemic evolution. Additionally, these patients have a poor outcome with any treatment. They are not responsive to hypomethylating agents, lenalidomide, or allogeneic transplantation. In the international consensus classification of myeloid neoplasms, we decided to create the new category MDS with mutated TP53, which is defined by peripheral blood cytopenia, less than 10% bone marrow blast, and presence of a TP53 multi-hit state or a combination of a TP53 mutation with a variant allele frequency of at least 10% plus complex karyotype. A very common condition in hematology is cytopenia of undetermined significance. These patients have no associated disease. They have no anemia associated with known causes, and therefore is difficult to define their prognosis and their potential treatment. Luca Malcovati, a few years ago, decided to study the diagnostic value of mutation status in patients with cytopenia of undetermined significance. And the study showed that the presence of somatic mutations was extremely important for clinical outcome of these patients. So subjects with no somatic mutation had a overall good outcome with a very low risk of progression to myeloid neoplasms, primarily MDS. By contrast, patients with at least a somatic mutation in a gene recurrently mutated in myeloid neoplasm had a worse outcome with a very high risk of progression to a myeloid neoplasm. By 10 years, almost all patients had progressed to a myeloid neoplasm. Therefore, in the international consensus classification of myeloid neoplasms, we have defined the condition clonal cytopenia of undetermined significance, or CCUS, which is characterized by persistent unexplained cytopenia, is sufficient criteria for diagnosis of MDS. These patients have less than 10% dysplastic cells in each lineage, erythroid, granulocytic, and megakaryocytic, and have a bone marrow blast count below 5%. Extremely important is the presence of a somatic mutation with a variant allele frequency of at least 2% in a gene which is recurrently mutated in myeloid neoplasms. So the three examples I have discussed with you underline the importance of gene sequencing for diagnosis and risk stratification of myeloid neoplasms and myelodysplastic syndromes in particular. We currently use morphologic assessment of bone marrow and peripheral blood and chromosome binding analysis. A few academic centers are combining chromosome binding analysis with gene panel sequencing. But we believe that in a few years, the conventional approach to diagnosis and the risk stratification of MDS will extend and use whole genome sequencing for somatic mutations and germline testing for the identification of predisposing mutations. Thank you very much.